Thank you. Good morning once again, everyone. I'll be talking to you on endogenous endophthalmitis and retinal abscesses, something that we see not so uncommonly in India, and certain things that we do to optimize the outcomes and the microbiologic yield. I have no disclosures in relation to this presentation. So as we are aware, in contrast to post-operative endophthalmitis, in endogenous endophthalmitis, the focus of infection is deep and it is systemic. So it doesn't come from the cornea side, it actually comes from the choroidal side. But when the inflammation and when the vitritis is too much, you can also have the anterior segment inflammation, which extends from the posterior segment to the anterior part. Now, what is known in the existing literature regarding endogenous endophthalmitis is that though we do not have a structured study proving this, most retrospective studies tend to suggest that you are likely to have a better outcome with respect to your clinical visual improvement, anatomic success, and also with respect to getting a microbiologic yield on your evaluation if you do a vitrectomy as compared to just a biopsy or tap, very much on lines of what Dr. Hattenbach spoke in his talk. So if you look at certain surgical scenarios, we will look at certain steps that help us optimize both the outcomes as well as the microbiologic yield. So the first situation is the most commonest one that we see, where we have endogenous endophthalmitis filling the posterior segment and then having some spillover inflammation in the anterior chamber. So this inflammation in the anterior chamber obstructs your visualization, so you can have some surgical maneuvers to clear this off so that you can have access to the posterior segment. And as again mentioned by Dr. Hattenbach, it is always great if you can go in, induce a PVD, detach the posterior hyaloid and clear out the vitreous cavity as much as possible. It's very parallel to a surgical principle that in general surgery, if you have an abscess somewhere, you would want to incise and drain rather than just sort of inject antibiotics inside it. So let us look at this video. Yeah, it's playing. So I'm taking a vitreous biopsy first. The cannula is in place, but the infusion is not on so that I can get a pure vitreous sample. Once that has been done, you are seeing these fine exudates in the anterior chamber. You can use viscodissection to push them away. And you can also bring in an iris repositor to sort of dissect them off the iris so that they then become loose and it is easy to clear them off from the anterior chamber. This maneuver also helps to release any synechiae that may have formed between the iris and the crystalline lens. And here after the core vitrectomy, as you see, I'm inducing a posterior hyaloid detachment. Once that is done, all the exudates separate out from the retinal surface and the surgical step then becomes relatively easy, relatively safe, because you know that you are away from the retinal surface and any surgical maneuver is not going to harm the retina. You can actually take the help of indentation and wide angle visualization to clear right till the periphery. And here you can see we could reach the retina, and that also gives you an opportunity to actually have a view of the retinal health, and thus you can have some sort of a prognosis as to how the patient might do in post-op. A second unique situation that we often come across in our part of the world, fungal endophthalmitis is not uncommon. In fact, 25 to 30% of all endophthalmitis that we see in India are fungus. We have this one subset which is Candida endophthalmitis, and there morphologically we on table tend to see a stalk which connects the disc to the area around the fovea or the central macula. So you will see that demonstration in this video. Here again we see vitritis, a string of pearls appearance in the vitreous cavity, which sort of indicates that this is likely to be a fungal endophthalmitis. And if you see here, there is a peripheral vitreous detachment that is already present. So I clear out the vitreous from outside in. And as we reach the posterior pole, I would draw your attention to this stalk, which is connecting the disc to the area around the fovea. So this we have seen very typically in Candida fungal endophthalmitis. And this is where you sort of cauterize out the stalk and ensure that you enter that cleavage plane between the retina and the stalk. And then on both ends, towards the disc as well as towards the fovea, trim it down and clear the stalk out. So this ensures that after you have done a vitrectomy, there is no residual traction on the macula and you are likely to have an optimum visual outcome. Another situation is an endophthalmitis which presents with vitritis and a frank macular abscess on the posterior pole. So this is a patient who was immunocompromised and came to us with loss of vision in both eyes. And as you can see, there are prominent macular abscesses right there on the posterior pole. So as the fundus photo is suggesting to you, you can see that it is largely clear. So what it tells you is that there may not be much vitritis, but there is definitely an infectious focus which is right there on the retina. Thus, if we take a vitreous biopsy which is parallel to what I showed in the first video, you are likely to get the biopsy from the anterior vitreous, and that vitreous may not be infected much, and your biopsy thus may come out to be negative. So how we approach here is something that we published recently. So we tend to approach this under air to ensure that you are able to reach the posterior hyaloid, you are able to reach close to the macular abscess. At the same time, because you're doing this under air, you do not dilute the vitreous cavity while you're performing this maneuver. So we'll see that in this video. This is the same patient, and as you see, the infusion cannula is connected to air. So as I'm doing my initial core vitrectomy, the air keeps coming in. This maintains the tonicity of the eyeball, but at the same time ensures that the vitreous is not diluted. Once I am close to the posterior aspect, I am again inducing a posterior hyaloidal detachment. And once that detachment is done, this is the time at which I decide that I will take the sample. So the cutter on the outside is now connected to a 2 cc syringe. You can see the wise ring coming up. And at this point, the sample is taken. Thus, you are sure that you have engaged the most infectious part of the vitreous cavity, and you are more likely to get a good microbiologic yield. And this is what the patient ended up with a scar and improvement and control of the endophthalmitis. So a last situation, this is again an immunocompromised patient. This was a patient who had renal transplants, was on immunosuppressives, and then came to us with reduction of vision. And as you can see here, the eye is largely quiet, but what you see is a yellowish lesion right there at the fovea. And the OCT very clearly demonstrates to you that it is in the subretinal space. Given the entire clinical scenario, this is likely to be infective and more often than not fungus. But then, like what I showed you in the previous videos, none of those maneuvers can actually reach this part right there in the subretinal space. So what do we do here? Here we would want to take sample from this particular abscess. So you go ahead, do your core vitrectomy, you induce your posterior hyaloid detachment so that you have cleared out all the vitreous from over the lesion, and then take a 41 gauge needle, and as I'm showing in the video, just puncture it. Just keep looking at the needle part and you will see this, the whitish abscess rising into the needle and getting collected. So this sample got collected, and then when we send it to microbiology overnight, it grew fungus, and we injected the patient with amphotericin B, and this was the final result. So you see, 41 gauge needle can be very easily and safely used in such scenarios. So in conclusion, endogenous endophthalmitis is a deep-seated infection. Sample acquired with extensive vitreous clearance and from closer to the retinal surface is likely to yield a greater microbiologic success, and this also ensures a better clinical improvement for your patient. Thank you so much for your patient listening.
Well, thank you so much also for the excellent videos and pictures. And